You know that feeling, right? It's 2 a.m., you are dead tired, and you just cannot stop hacking. We've all been there. Well, what is going on, wonderful people? Today we are diving into a super high-energy masterclass on the pharmacology of coughs and antitussive agents. Welcome to this special confused neuron explainer. We're going to treat this exactly like a whiteboard session today, so I'll be verbally drawing out the concepts, highlighting the big takeaways, and using lots of contrast so you can map this all out in your brain perfectly. All right, grab your mental markers, focus up, and let's get right into it. Okay, let's tackle the very first and honestly most crucial question on our board. Why do we actually cough? And maybe more importantly, what is the absolute most dangerous thing about giving the wrong cough syrup to the wrong patient? I mean, just imagine giving a medication that completely stops a cough to someone who is actively drowning in their own mucus. You could cause a massive, life-threatening obstruction. So before we even think about looking at a single drug, we absolutely must understand the fundamental difference between a productive and a dry cough. Now, what's really fascinating here is the definition itself. Contrary to what a lot of people think, coughing is usually a highly protective mechanism. Think about it like pulling your hand away from a hot stove. Your respiratory system reflexively coughs to clear out bacterial sludge or foreign irritants. It is literally defending you from your environment. Antitussives, on the other hand, are the pharmacological agents we use to suppress this reflex. But the golden rule is we only use them when this normally helpful reflex goes completely rogue. Let's draw out the pathophysiology and see how this all connects. A great way to remember this is the SRACER mnemonic. That's stimulus, receptor, afferent, center, efferent, response. So, step 1, an irritant hits your respiratory mucosa. Step 2, chemoreceptors trigger the afferent vagus nerve. That's cranial nerve number 10, by the way. Step 3, the signal travels all the way up to the central nervous system, specifically hitting the medullary cough center in your brainstem. And finally, step 4, the efferent motor signal fires right back down to your diaphragm and intercostal muscles, causing a forceful contraction to expel the air. Boom! That is your basic cough reflex arc. So the single most critical point is classifying the cough before you even try to treat it. I want you to picture this highlighted in bright neon yellow on our whiteboard. If your patient has a wet, productive cough from a bacterial infection or COPD, your primary goal is to help them expel that mucus. Do not suppress it. But if they have a dry, non-productive, hacking cough, maybe from allergic rhinitis, that is just totally exhausting them and keeping them awake all night, well, your goal switches. That is exactly when you want to suppress the reflex. We can essentially attack this annoying reflex using 4 main classes of pharmacology. Number 1, we have opioid antitussives. Number 2, non-opioid antitussives. Number 3, mucolytics, which chemically destroy the thick mucus sludge. And number 4, expectorants, which basically help pump that sludge right out of the lungs. Let's break these down one by one so they stick. Let's contrast our big guns first. On the left side of our mental board, we have opioids. These act centrally. They actually cross the blood-brain barrier and just smash that medullary cough center right in the central nervous system. Now, on the right side, we have non-opioids. While some of these do act centrally, many are what I call peripheral silencers that work locally right inside the respiratory tract, directly anesthetizing the stretch receptors in your lungs. All right, let's talk about codeine. Codeine is basically your classic, textbook opioid antitussive. Its mechanism of action is brilliantly simple. It fundamentally decreases the sensitivity of those CNS cough centers in the brainstem to any peripheral stimuli. And what's actually pretty amazing is that it suppresses the cough at doses much, much lower than what you would normally need for pain relief or analgesia. But as we always say in pharmacology, there are no perfect solutions, only trade-offs. You really have to beware the classic opioid side effects here. Yes, you suppress the cough, but you also freeze up the bowels. Constipation is a massive side effect because opioids inhibit GI motility. You also risk dysphoria, severe fatigue, and, addressing the elephant in the room with absolute clinical seriousness here, high addictive potential. Given the devastating reality of opioid addiction worldwide, codeine's use is becoming much, much more restricted. Moving on, next up is dextromethorphan, which you've probably seen a million times as DM on your over-the-counter cough syrup bottles. Chemically speaking, it's actually a synthetic derivative of morphine. But here's the kicker. It has absolutely zero analgesic effects at its normal antitussive doses. So how does it work? Well, it acts as a central excitatory amino acid NMDA receptor antagonist and a sigma-1 receptor agonist, successfully shutting down the cough reflex without numbing pain. Now, what's the catch with DM? Well, it generally has a way better safety profile than codeine at normal doses. If someone takes a massive dose, it literally turns into a crazy dissociative anesthetic. We're talking similar effects to ketamine or PCP at super high doses. And because of standard side effects like drowsiness, dizziness, and nausea, it is strictly contraindicated in atopic children and absolutely should never be given to kids under 4 years old. Okay, let's move away from the brain and travel down into the lungs. Enter benzonatate. I love to call this one the peripheral silencer. Unlike the central-acting opioids, benzonatate works completely peripherally. Its mechanism of action is literally anesthetizing the stretch receptors located right in your respiratory passages, lungs, and pleura. This triggers a beautiful cascade. No stretch signal means no afferent impulse, which means no cough. And guys, this brilliantly illustrates exactly why you need to know your pharmacology inside and out. Here is a cautionary pro tip I'm mentally drawing in huge, bold red letters on our board. Do not chew the capsules. If a patient chews a benzonatate capsule, the localized anesthetic effect will rapidly numb their entire mouth, tongue, and throat. That isn't just annoying, it can be incredibly dangerous and completely compromise their airway reflexes. So tell them to swallow them whole. Just to round this out, here are a few other non-opioid players to keep in your back pocket. First up is noscapine, which is surprisingly derived from the opium poppy, but acts through a non-opioid pathway, hitting sigma receptors with zero narcotic buzz. Then there's chlorphedenol, a centrally acting agent with a really slow onset that can annoyingly trigger vertigo and irritability. And lastly, prenoxidazine, which acts locally to desensitize those bronchial stretch receptors for bronchial coughs. Okay, let's totally pivot. What if the cough is productive? Remember the golden rule. You do not suppress it. Instead, we use mucokinetics. Let's split the board again. On one side, we have expectorants, which increase the volume of bronchial secretions to facilitate their removal. On the other side, we have mucolytics, which use pure chemistry to degrade mucin polymers and slice right through the viscosity of the phlegm. Treating a wet cough without knowing the difference is like being a butcher without a knife. Let's see how they work. Guaifenesin is your classic, reliable go-to expectorant. It stimulates vagal pathways in the gastric mucosa to reflexively increase your respiratory tract secretions. Think of it like adding a ton of water to a dry slip and slide. It just enhances the clearance of bronchial exudate and helps you hack that mucus right out of your chest. You'll actually often see it combined in over-the-counter syrups with codeine or DM. Then we have the absolute heavy hitter mucolytic N-acetylcysteine, or NAC. This is pure, beautiful chemistry in action. NAC contains exposed sulfhydryl groups that chemically interact with and literally destroy the tough disulfide bonds holding the mucoproteins together. It essentially slices through thick, viscous respiratory mucus like a hot knife through butter, making it infinitely easier for the patient to clear their airways. But there's a pretty dangerous catch with NAC. When you administer it via aerosol, there is a real risk of epithelial damage, but more importantly, aerosolized NAC can severely irritate the airway receptors and trigger reflex bronchoconstriction. So if you are giving a patient aerosolized NAC, you better administer a bronchodilator first, or you are going to send them into a totally preventable and scary respiratory spasm. And then let's not forget bromhexine and ambroxol. These are potent mucolytics derived from plant alkaloids. They do a totally beautiful job of dissolving hard phlegm and stubborn mucus plugs. However, the side effect profile includes making your patient a bit of a leaky faucet. They often cause rhinorrhea, which is just a fancy word for a runny nose, along with lacrimation, meaning watery, tearing eyes, and some gastric irritation. Speaking of nasty mucus plugs, chronic smoking is the ultimate villain here. When we map out its effects, it causes persistent mucosal inflammation, leading to chronic mucus hypersecretion. This creates a persistent cough with heavy sputum, basically the ultimate progressive wet cough nightmare that we know as chronic obstructive pulmonary disease, or COPD. This airflow obstruction is largely irreversible, making smoking cessation the absolute most critical intervention you can offer. All right, let's wrap this all up on our whiteboard with a crystal clear treatment algorithm. Step 1, identify the underlying etiology. Ask yourself, why are they coughing? Step 2, if it's a wet, productive cough, do not suppress it. Give them an expectorant or a mucolytic to help them clear it out. And step 3, if it is a dry, spasmodic, totally exhausting cough with absolutely no mucus, that is when you safely drop the antitussive hammer using DM, benzonatate, or codeine. Ultimately, always ask yourself this final, provocative question before you ever write that prescription. Are we helping a vital, protective reflex do its job, or is this cough merely harming the patient and keeping them awake? Knowing the difference is exactly what separates a good student from a truly great clinician. I hope you absolutely loved this explainer. Stay curious, keep mapping things out, and I will see you on the next